just started.
Okay.
We'll wait for a few minutes.
Yes. Oh, they're coming in.
Should have some music in the background. Let's wait another couple of minutes. See if more people come. I still see people coming in, so I'm grateful for the others to wait for a few more minutes.
Yeah, they usually trickle in for the first 3 to 5 minutes.
Jeannie, will you tell me when to start, or?
Yes.
I think we should start.
Okay.
Okay.
No.
So good afternoon to everybody. My name is Damiano Rondelli. I'm in the College of Medicine Center for Global Health. And I'm very honored today to introduce great speakers, especially because this is the Breast Cancer Awareness Month. And we couldn't actually have a better venue than talking about breast cancer in Nigeria today with the great speakers. This is one of the colloquia of the UIC Global Health Colloquium that we organized together with other colleges, College of Medicine, Nursing, Applied Health Sciences, Pharmacy, Dentistry, and the School of Public Health and Social Work. So we are happy to share this experiences with all over the campus. And just a couple of issues that we will have at the end, some time for questions. Please write your questions in the Q&A section or the chat, and I'll make them available to our speakers. Also, before we start, I want to make just a small announcement we're going to have another colloquium next month, early November. will be organized. The speaker will be, hold on a second, if, assistant professor in kinesiology. Hold on. I'm looking for Dr. Vanessa Otto will be the speaker for next month. And Dr. Otto is an assistant professor in kinesiology and nutrition. And she's interested in employment and overweight in low middle income countries. So we look forward to the next colloquium next month. So I think we are ready to start today's colloquium. I want to introduce briefly our two speakers. First, we'll introduce Dr. Omolara Fatiregun. Dr. Fatiregun is a lecturer of the College of Medicine in Lagos State University in Nigeria. She's also an honorary consultant and clinical radiation oncologist at the Oncology Cancer Screening and Treatment Unit at Lagos State University Teaching Hospital in Lagos. She's a fellow of the West Africa College of Surgeons, Faculty of Radiology, Clinical and Radiation Oncology, and as well as an associate fellow for the National Postgraduate Medical College of Nigeria. She received a fellowship award at the University of Chicago and another fellowship in Africa, in South Africa. She has received actually multiple awards, including one in the University of Birmingham in the United Kingdom in 2017. She's currently a research committee member of the African Organization of Research and Training in Cancer, as well as a PI in a side PI for a transatlantic prostate cancer consortium. She's also a co-PI of a trial in breast cancer in Nigeria. And she's also a member of the American Society of Clinical Oncology. Welcome, Dr. Fatiregun. We are very honored that you took the time to be with us today. I know for you it's late in the day, and thank you for joining us.
Thank you.
You're welcome. Together with Dr. Fatiregun, I'm very pleased to introduce you to instead our faculty, Dr. Abiola Ibraheem. Dr. Ibraheem is a faculty in the Division of Hematology Oncology in the Department of Medicine here at UIC. She recently joined us. She was prior a faculty at University of Chicago. Dr. Ibraheem trained in Nigeria, actually worked for a few years in Nigeria as an internist there. And then he moved to the United States, where he did her internship and residency in Atlanta at Morehouse School of Medicine. And then he came to Chicago, where he did she did her fellowship at the University of Chicago, where she also stayed as a faculty after that. Dr. Ibraheem is a special faculty for us because she has a special interest, a research interest in developing clinical trials in low middle income countries, in particular in Nigeria. She's a breast cancer oncologist as her own specialty, and she has been doing research now for years. Excuse me, in Nigeria, being a pioneer together with the Nigerian colleagues in trying to develop clinical trials in oncology in this country. With this, without any other overdue, I want to. I don't know who will start the lectures, but I welcome both of you, and we look forward to your talk, and we'll be ready with questions at the end. Thank you.
Thank you.
Abiola, do you want to? Wow.
So Dr. Fatiregun will be going first with her talk about the state of breast cancer treatment in Africa and Nigeria. Thank you.
Okay. Thank you, Dr. Abiola and Damiano. Good evening, good afternoon to everyone on the call, depending on, I know it's the Major League UIC community that we have on today. It's evening here for us in Nigeria, and I must really appreciate the organizers of this webinar, because I mean, collaborations like this, like I mentioned before we started the call, actually leads to capacity building in Africa. So today I'll be talking about, I'll start the discussion by talking about the real-time, so let me just share my screen. So real-time management for breast cancer in Africa, capacity building. I think I should switch off my camera so that it doesn't go off at any point. Anyways, so Africa is the second largest and second most populous continent after Asia in both cases. And we know that the population of Africa is about 1.3 billion, covering about 1/5 of the total land surface of Earth, and culturally diverse, even genetic. We're beginning to see several disparities genetically, and we know, there's several ethnicities in Africa. Now, out of the 54 countries, 46 of these countries are actually classified as low middle income countries and low income countries. And that's why you see that there's several inequalities across Africa, because even based on this classification, Nigeria is the most populous in Africa. And we know, female breast cancer has become the most commonly diagnosed cancer in most African countries. So looking at this diagram, it's actually an interactive map from the International Agency for Research on Cancer. You see that breast cancer ranks first in most of African countries. You see the navy blue marking shows countries in which breast cancer is the first, and the light blue color shows those that it's second to cervical cancer. Incidence and mortality, you see that the rising incidence. And also, if you look at North America, the incidence is high because they're screening, they're picking up these tumors higher. But you could see that the gap between incidence and mortality, you see it's actually wide as compared to Africa, that you have 40 to 20. That's the picture that we see in Africa. And I tell you that most of these cases are underreported, as we'll see as I go on in the presentation. Risk factors when it comes to breast cancer in Africa, we have a variation of risk factors between African countries and high-income countries. When I was training and we were reading all the foreign textbooks, we had crammed a lot of risk factors that was relating to breast cancer. But then when we got to the clinics, it was different, right? You notice that the characteristics in Nigerian women, I practice in Nigeria, is definitely different from that of what we read in the books. Now, some of the studies have actually backed this up. You can see that studies have found an inverse relationship between age, menarche, and BMI, with breast cancer risk. Because in Africa, most breast cancer patients have higher mean number of children, right? They have their first pregnancy at younger ages, and they breastfeed for a long period of time, right? Nullifying that risk factor that talks about, what's the name? So they because it's cheaper, right? They have lower mean age at menopause, and there's lower prevalence of use of contraceptive use and lower alcohol consumption. So, this necessitates more research when it comes to risk factors for breast cancer in Nigeria. And that's why we're always excited to have international collaboration when it comes to setting up studies. Screening, there's increasing awareness of breast cancer screening. That's the truth. A few surveys that we've taken up in the community has shown that people are aware, they're getting aware, right, of breast cancer. And they know they're supposed to do the self-breast examination, especially in the urban centers. But what about the costs of screening? A woman walking up to get mammograms done, when she has to feed her family. There are several efforts from state governments non-governmental organizations and even international organizations, with regards to increasing the knowledge, the awareness when it comes to breast cancer, screening and the likes. But then cost, plays a major role. With regards to mammography, most African women would present premenopausally. And so you see the 2D mammograms just white out, right? And so is that effective enough in screening women in Africa? There's limited access to 3D mammograms. It's available. For example, in Nigeria, we have 3 centers that have 3D mammograms installed. But what is the coverage like, when it comes to screening for breast cancer? Then also the cost of getting a breast MRI, which is about $200. So the average woman who makes about $50 per month, and then she's to go for this 3D MRI, what is she going to choose? I mean, when it comes to screening. So that's why you have good uptake of the breast self-examination, and then, amongst those women. Breast cancer in African women tends to differ, like, for example, with the age of presentation. Usually you have an average about 35 to 45 years, even younger. I've had 19-year-olds present in clinic with bilateral breast cancer, 10 to 15 years earlier than women in, from high income countries. And you see this publication from Professor Venapuye at the Kolebu Hospital. What they tried to do was they tried to assess the clinical presentation of breast cancer. And if you look at the median age of diagnosis, in Kenya, Nigeria, you see the age is around that 45, but places like Cape Town, South Africa, 56. Cape Town is a middle income country. It's not an LMIC. And you see Tanzania, Morocco still having that. So they tend to come in earlier than women in high income countries. Then what about presentation? So it kind of raises the question that these tumors that occur in African women, they tend to be much more aggressive, because you can see that in Kenya, as high as 86% would present with advanced stage diseases from 3 to 4, and as high as 72%. I've had patients come to me and say, oh, I only felt the lump a few months ago. And then they are here with, quite advanced stage disease. That calls for research. Much more research in that area. Many women would come with triple negative cancers, and you see is as high as 20%. That's across Africa. And another thing we notice in clinics is that there's a difference, even with the other molecular subtypes, there's difference in response to treatment, right? I mean, a woman comes to you with ER positive disease. That doesn't mean, oh, you're excited, because we find our women progressing even on the standard of care. So is there a different biology, when it comes to this molecular subtypes amongst African women? In terms of management, mastectomy and breast conserving rates, of course, they're really high across developed countries in Europe, 30%, 70%, you can see there's higher breast conserving rates. But in Africa, most women are offered mastectomies. Why? I mean, there's limited access to radiation therapy, to sterilize the remaining tissue. So you find the surgeons going for mastectomies instead of trying to conserve the breast. The woman might be very far from where there's radiotherapy. We'll be getting to that later on. Or, when she even gets to the radiotherapy center, the queue itself is another. So most women will be offered mastectomies. But for us in urban centers like Lagos, we have about 5 machines. And so we're able to offer our women breast conserving surgery, and with the option of getting radiation as soon as possible. But of course, when you look at countries in which they do not even have a radiotherapy machine, like Benin Republic, Chad, these are people who feed into Nigeria for services like that. And then there's that point of cost of treatment too. Quality of breast cancer, of course, is improving, but of course it requires more training for the surgeons, the oncology skills and improving access to care for patients. in the clinical oncology space now, most treatments, most breast cancer treatment offered is according to the international guidelines. You find us using things like NCCN guidelines, ESMO. Then we even have some localized guidelines which have been adapted from NCCN guidelines. So because the truth is that most of the clinical trials that were used to develop those guidelines don't actually include women of African descent, right? And so you begin to wonder, like I mentioned, that even those with molecular subtypes will progress on your standard of care. So what exactly is going on? The other thing is that those clinical trials were developed in different climes. When you import such an innovation into Africa, we have challenges of adaptability, feasibility. How do you have a technology that was developed somewhere else, and then you want to implement it in Africa. We struggle with that, temperature-wise, and there are a lot of other factors. Most drugs are available. Now we have a global village, especially in urban centers. Rural centers will definitely suffer more when it comes to getting access to some chemotherapeutic drugs. But for us in the urban centers, there are pharma companies on ground. There's Roche, there's Sanofi, AstraZeneca. They have offices, they have their presence in Nigeria, but are they set up to do research, right? That's one factor. Then access to this care, when it comes to the cost of treatment, right? Because most payments are done out of pocket. And I also mentioned here that, when we talk about adaptability and feasibility, it actually raises that need again to have LMIC sites included in clinical trials. Because the truth is that it also serves as a form of reverse innovation. I tell people that when you have a clinical trial site in Nigeria, everyone that's going to be in that trial will be of African descent. And then you can actually properly study breast cancer in that population. Dr. Ibraheem is still going to speak on our experience with the breast cancer clinical trial, the ARETA trial, later on. The other thing we did was there is a new NCCN for Sub-Saharan Africa. And basically it's meant to scale up, right? When we have evidence from this part of the world to adapt our own guidelines so we can properly offer treatment to our patients. Systemic therapies like chemotherapy, targeted, hormonal, they're available, especially in the urban centers. But of course, the rural centers, we have only limited number of clinical oncologists. We're about 80 to a population of 200 million people, for example, in Nigeria. And in other parts of Africa, you have that gap too, when it comes to availability of either medical oncologists or clinical oncologists. There's been a few initiatives like the CHI initiative to help reduce cost of treatment. So the CHI initiative is a Clinton Access Initiative, which started in 2015 in partnership with the American Cancer Society. And basically they set it up to help increase access, right? And strengthen the health worker capacity, also help the government. So CHI and the ACS signed an agreement with Mylan, Novartis, Pfizer, in 2017. And that's majorly to provide access, cheap drugs. So now we currently have 20 life-saving cancer treatments in 26 countries in Sub-Saharan Africa and Asia. And the focus is breast, cervical cancer, and prostate. So what they do is they collaborate with institutions, federal institutions across the countries. So this is a snapshot of, this is also an interactive site. You can see that all the dots on the African map are places where you have presence of the CHI initiative. And you see Nigeria, they're also part of this initiative. In terms of insurance coverage, there are other countries have their different packages, but it's limited when it comes to in Africa, in most LMICs. For example, our coverage in Nigeria is still limited. We're still pushing and advocating to include more medications, cancer medications on the National Health Insurance Scheme, then you also have these private insurance companies that are able to cover for cancer medications. But of course, that is for the private patients, the high income earner who is able to pay for those drugs. And what is the coverage like? That's the question. But when it comes to availability, there are insurance companies that are able to cover. And it still boils down to, if you have just few private people being able to, what happens to the guys in the government setting? So, I mean, at least these initiatives like the CHI initiative has helped, especially federal institutions. Then other systemic therapies, I mean, it continues to rise. Other patients, I mean, not who can benefit from these insurance companies or even on the National Health Insurance Scheme will pay out of pocket. And one of the things that the insurance companies would say is that they need data to justify inclusion of that service, like radiotherapy or the treatment service, inclusion of that treatment on their scheme. So we need more research. At least if we have more collaborations, we have more studies, you know, we can definitely have enough data to push for more from that end. So this is just, this was published in 2019. And what this study tried to explain was like available treatments and out-of-pocket costs, you know, during the study period. So they studied Namibia. Namibia is a middle-income country, which is also in Africa. Then Nigeria, LMIC, Uganda, LMIC. So you see that most of the things on Namibia's list is free, the coverage. And for Nigeria, you see, for every, the ratio between those attending the public setting and the private patients. And you can see the cost of mammograms, CT scans, $145, biopsy, $85. This is, I mean, how many people can actually afford this? And so they are available, but also we need to look into affordability. Immunohistochemistry is available and it could go as high as $100 to get the test done. And then you have other forms of medication that's out of pocket cost. So we say that cancer treatment is financially toxic in this part of the world. It's toxic to, I mean, most patients. With regards to radiotherapy, the IAEA has on its website that number of radiotherapy machines per million people. And you see that for those who have 5 or more, they have this deep green color, and that would include things like places like Europe, the US, and the likes. But for us in Africa, you can see that less than 1, right? Except for places like South Africa and the northern part of Africa. You see in Nigeria here, we have less than 1 per million. And you can even see centers around there not having access to radiotherapy, right? Like Togo, Benin, I mentioned this before. There are no reported machines there. So they have to come all the way to Nigeria to get access to that treatment. Things have really improved in Nigeria because since 2016, we've been pushing for establishment of more radiotherapy centers in Nigeria. So in Lagos alone, we have about 5 machines now. And linear accelerators that have capacity to do IMRT treatment, IGRT, we have in the private setting, and we have in several centers across Nigeria. Also 3D brachytherapy. Several PPPs are in the pipeline. For example, my own hospital, we're currently in discussion with a Turkish organization to help set it up. Lagos State, UBTH, so centers are popping up in Nigeria because, there has been strong advocacy along that line. When it comes to, research, I keep talking about inclusion in clinical trials. We know that initially in the past, we used to talk about the quality of our stored blocks, pathology blocks and the likes. But I think we've moved from that. We've moved from that now because we've had several trainings from Novartis. We've had the capacity training for pathologists for example, in my own institution. There's still places that, of course, they still lack that that there's still some level of inadequacy. But for us in a place like Lagos, which is an urban center, we've moved forward. This study that I showed, I clicked in this slide, was something that was one of the studies conducted at my institution, was one of the sites. And basically what it was, a Novartis funded study. And basically what they did was they controlled everything from biopsy to fixation. Our lab scientists were taken to the Novartis lab in Boston for training. Our pathologists received training on, slides review, immunohistochemistry, and the likes. And there was genetic also testing, sampling with regards to during the study. And so one thing we found out from this cohort was that most patients you see in the Nigerian cohort had more of triple negative breast cancer, followed by the HER2 neu, right? Then the hormone receptor positive disease. So when you compare it to Blacks from other parts of the world, like the Caucasians too, you see the ERPR positive disease is much higher. Whereas in the Nigerian cohort, you see how the levels at which it is. With regards to genetics now, mutations, we have more of P53, right? Really high up there. Then things like GATA3, right? So basically this is just one of those studies that actually show that, helped us to define the molecular landscape of cancers in Nigeria. When like I mentioned, this NCCN Sub-Saharan Africa, we still have to scale up because we still have low levels of evidence, right? When it comes to research publications in LMICs, because we know that there's poor research funding. This study that we published in the Journal for Global Oncology actually showed that, based on study designs that we have, type of studies that have been conducted with regards to breast cancer from 1963, you see that there is an increase, right? It's actually exciting that, we're having much more publications on breast cancer, but you can see that most of the studies are either case series or cross-sectional studies, and you see that the clinical trials, just 3, right? As at the time of this publication. So the levels of the research, breast cancer research will really support evidence-based medicine in Africa. Is still, especially in the LMICs in Africa, is still a little bit low. Most of the clinical trials, international clinical trials, go to places like South Africa, go to Egypt. There's need to include more LMICs in those clinical trials. Still speaking on inequalities in breast cancer treatment across the Sub-Saharan Africa, this study was published 2019. I showed this picture before, and I just wanted to, further reinforce the differences in the, different African countries in when it comes to breast cancer treatment. Cancer registries, they're a major tool for developing effective cancer control plans. It's better. We now have there's several cancer registries across Africa. For us in Nigeria, we have the Nigerian National System of Cancer Registries. That's just one, right, of the initiatives that just pull up the data on cancer in this part of the world. But we still have underreporting due to inadequate funding of cancer registries. But we're waking up to it. For example, my own institution, which is part of the National System of Cancer Registries, recently upgraded our hospital-based cancer registry to a population-based one. So we're gradually moving there. We're waking up to it, and funding is gradually creeping up. I hope we'll get there. But the exciting thing is that the International Agency for Research on Cancer has started this global initiative for cancer registry development. And basically they have hubs across the world, right, in different parts of the world. And we have about 30 current AFRCN members across 19 countries. That's in Africa. And I have a list, in different parts of Africa. For us in Nigeria, these are our own collaborating centers, that are part of this, the global initiative. You see, that's my institution there, also part of it. And then we have all these other institutions also as being part of the hubs. So in conclusion, there's a slight improvement in breast cancer management in Africa. We are not yet there, but when you look at the settings, that there's a private setting, there's a public setting, we have the drugs available, but what about the coverage? Affordability still remains a major challenge, and there's need for more breast cancer research to further define the genetic, the pathologic, and treatment and survival landscape breast cancer in Africa. There's need for more budgetary funding for cancer treatment and research. We're pushing. You see, there really isn't a direct grant system that actually helps you conduct cancer research. Everything is lumped up in one particular grant called the TED Fund grant, and everyone is competing for it. So if you look at the budget for health, it's very small when compared to that of developed countries. Then there's also need for, increase in the insurance coverage for breast cancer management across different types of surgical, medical, or even radiotherapy across Africa, especially in LMICs, and the need for clinical trial sites in LMICs, as well as inclusion in international trials. I've mentioned before that whenever we develop an innovation in a different part of the world, adapting it to our own context is always a challenge. But if we have sites here, then we can definitely have an all-inclusive clinical trial that covers, different race and with very strong representation of women from African descent. These are my references. Thank you.
All right. So, I will go ahead and share my slide. All right, thank you very much, Dr. Fatiregun, for that very wonderful talk. So we'll move on to the next talk, which is talking about the benefits and challenges of breast cancer clinical trials in Nigeria. So you've heard about how the current status of management and also the need for clinical trials in African countries. So we'll be talking briefly about global cancer incidents and also globalization of cancer clinical trials. And then we'll hone on cancer trials in Nigeria and talk about the benefits and challenges of the trials in Nigeria. So like Dr. Fatiregun already talked about the incidence and mortality, and this slide just further hones on to what it is, whereby when we look at the incidence and mortality of cancers in high-income countries, you see that there's a difference. But then in African countries, it's almost the same, whereby most of our cancer patients, when they show up, they're more likely to die from their disease compared to high-income countries. So when we look at clinical trial distribution, globally, we see that now we are seeing westernization and we are seeing a move from the westernized clinical trials to other parts of the world, right? And now in some decades ago, when we talk about clinical trials, it's most likely conducted in the United States and what have you. But now people are moving to places like Japan, other West Europe, other parts of the world. And then when they talk about African countries in clinical trials, people stop at South Africa. And when they conduct clinical trials in South Africa, you see that most of the patients that they put on that trial are also of European descent. So what happens is that with the globalization of clinical trials and with the Black nations being ignored in clinical trial, this is going to cause disparity in minority patients as far as clinical trial results is concerned. So when we talk about cancer trials or studies in Nigeria, in African countries. Every time we talk about prevention, we talk about screening, we talk about mammogram and what have you, or we talk about epidemiology, observational studies. And we have to really start going beyond that. If we really want to close the global cancer gap, we have to go beyond all these things. We have to start involving low middle income countries, especially African countries, in cancer trials. And this is a benefit to us globally, which is now that we are talking about targeted therapies, we're talking about therapies to reduce minimal risks. If we still continue to ignore minority patients, what will happen is that our treatments are not going to be generalizable, right? As at now, we talk about, or when we talk about endocrine receptor positive breast cancer is more likely to be seen in European patients. But when they are seen in Black women, even the ones that are in the United States, we see that these patients actually do poorly. So now it comes back to genomic diversity, whereby we start asking ourselves questions in the science world, which is our treatment truly diverse? So to address clinical trials, Nigeria actually really did prepare for the last decade to join the world in cancer clinical trials. And what did they do? They started training the staff on GCP on how to conduct clinical trials. They shared standard operative procedures with high-income countries, especially institutions in high-income countries. And they went ahead to develop a lot of infrastructures that are like what Dr. Fatiregun had alluded to. And this partnership and collaboration was made possible with pharmaceutical industries like Roche Genentech and foundations like BCRF and other institutions I have to mention, like my former institution, University of Chicago, and other staff there were able to work with Nigerian academic staff to make this happen. So the successes of that has been the ARETA trial, which I'm also sub-PI on, that is actually the first biomarker multi-institutional trial in country. And we have LASUT, Ibadan, that's UCH, Ife, Luth, that are sites in the clinical trials. And then we have the soon to be open TAMAC trial also that I'm also a sub-investigator on. So these are not the only two clinical trials that we have ongoing in Nigeria. We also have some multiple trials that are going on in Nigeria from other clinical trial group in country. So I have seen the benefits of clinical trials, and this has really, really helped in capacity building. So we published a paper last year talking about this. And even from the time we published this paper last year, we've continued to see this capacity building and the benefit moving up tangentially. So I'm going to go through these benefits quickly in this talk. We'll see that initially before the trial came up, when we have breast cancer patients, before they get a molecular diagnostics, only less than 20% of them would get a molecular diagnostic test done before they start getting all kinds of treatment like surgical intervention or even chemotherapy. And this 20% is an average when you look at places like LASUT and even the private sector. And that's because the way it's built, the patient comes in with a breast lump, they do a biopsy, and then before it takes a while before the result comes out. And if it was a surgeon that sent for it, they've already started treatment. And even if they first of all order for H&E, and then it comes out as breast cancer, and then they move on to the next thing. So now with this trial, what we have done is that it has forced us to be able to do IHC, which is a molecular subtyping. And also we've created a system in place whereby since we are trying to get eligible patients on the study, we have to be able to screen all our patients. So most of the patients, especially in LASO, in all these 4 institutions that I've mentioned, have been able to get molecular subtyping. So moving on, again, I published a paper in 2016 talking about assessing the collaboration and teamwork amongst healthcare providers that treat cancer patients. So although we have not gone back to repeat the study, but what I see in real time is that there's more collaboration between everyone that takes care, all the healthcare providers taking care of cancer patients. So we have this call every week, and then whereby the team, multidisciplinary team, they meet together and they talk about their patients. And this has also moved on to building this team collaboration between providers in other institutions. So again, due to these clinical trials, we have already started having increase in documentation, because then we have to, as a habit, people are now, the providers in country are beginning to document treatment of their patients. And then so as to understand how many patients we're going to screen for, we're already keeping screen logs of new patients. And not only in breast cancer, this has also moved on to other disease entities. Again, we already talked about the infrastructure building. So we're able to acquire molecular biology laboratories with state-of-the-art equipment, and then they already were able to have clean rooms. So with the clinical trial, so we've also seen patient-centered clinical service delivery. And I always say that when COVID hit, was when a lot of countries were shutting down their clinical trial. Nigeria actually started their clinical trials in the midst of COVID, and it was a collaboration between policymakers, even our patients, and everybody showed up. Of course, they were protected and were able to get this trial going. And from this trial, we also have seen the need of building training programs like the pharmacology programs and like the medical oncology programs and what have you. All right, so when we talk about cancer clinical trials in low-middle income countries, especially in Nigeria, a lot of challenges comes out the bat, because in the global space, there are a lot of thoughts about conducting clinical trials in those parts of the world. Part of the concerns we have here is the global space is concerned about infrastructures on ground. And this is worthwhile, because then we'll talk about, okay, if you want to join the world in clinical trials, you have a PET scan. Can you do biomarker driven clinical trials? What about the pharmacogenomics of the trials? So yes, those are challenges out there. And again, the country is moving forward and improving on the research capability to be able to do all those technical trials. And then the other concerns is efficient regulatory or ethics committee processes, especially when there are strikes or when there are strikes in the country. So we have FDA, we also have IRB, and then we have NIREC, which are all these institutions that are created to be able to make sure that ethical trials are being run in the country. Although, as at now, initially, before we opened the ARETA trial, it took a while before we could do that, because before we moved the bureaucracy in all these entities took a while. But over time, the entities, for example, the FDA, the FDA equivalent, we call it NAFDAC, understood that they have to be in collaboration with the NIREC, which is the National IRB Committee, so as to get all the studies and trials moving forward quickly. So there's also concern about participant recruitment. In 2007, a study was conducted in Nigeria, in Ife, whereby we looked at metastatic breast cancer patients, and the study never accrued. So, and in some studies that has been done in Nigeria, the question of concern has always been the accrual of the study. But in our ongoing ARETA trial, we've already addressed that by making sure that everybody is on board, as far as and actively making sure that we seek to recruit patients on our studies. Then there's the concern of the standard of care. So the question now is, when you're going to globalize a trial, you have to make sure that, okay, the standard of care according to SCCN guidelines, because that's what we use in the cancer world. But in some parts of African countries or in Nigeria, some of this standard of care might not be delivered, right? So again, while we might not be able to do all clinical trials at the moment. But then this is a cry whereby this is a call for us being able to reach that standard of care. Because again, when we talk about global cancer equity, we cannot choose and say that, okay, the standard of care in African countries has to be different because of low resources. We have to be able to leapfrog to get to that level. So the physician-patient ratio is also a problem whereby, I kid you not, one oncologist in Nigeria, when you get to their clinic, it's always very alarming, whereby here we see, you can't see more than maybe 30 patients in a day, or maybe, let's just say 35 patients in a day. But in Nigeria, they can see as much as 50, 60, because it's a lot. The physician-patient ratio is ridiculous. In Nigeria, whereby the population is almost 200 million people, we have right now about 120 oncologists. And I'm guessing I'm exaggerating on that, because from a paper published, it was 80 oncologists. That was like about 7 years ago. I want to believe that some oncologists have graduated since then. So there's a huge gap between the physician and patient ratio. And then the other challenge that is concerning in the global space is, now when we bring all this targeted therapy into the country, and we want to do clinical trials, we do the clinical trials. So these drugs are too expensive for every regular person to receive. Right. So after the trial ends, do we stop giving the drug to the patients on the trial? How available will these drugs be to the general population? So through this clinical trial comes the equity, meaning that African nations and even through the African Union, we can actually start negotiating for drugs for all these therapies instead of relying on middlemen to bring the drugs in country. At that point, it's going to come from the pharmaceutical industry at a much discounted cost to our population. So then to start on the challenges of clinical trials on a patient level, clinical trial. So we're concerned about patient autonomy, right? In places like Nigeria, whereby there's hierarchy in the patient-provider relationship, there's always this concern whereby does the patient have the autonomy to say no if they are being asked to go on clinical trials? And then you start questioning the quality of this, the enrollment of the patients themselves. And then we're in a place whereby there's low health literacy generally. Cancer diagnosis is still a mystical diagnosis, and which is why we see our patient presenting late. There's a lot of religion around cancer. We don't even have a name for cancer itself, in our local dialect. So that's a question whereby a lot of people, we don't really talk much as far as the cancer treatment is concerned. And in places whereby the health insurance is not, cancer is not well covered with most health insurance. And even most of our patients, when they present, majority of them do not even have health insurance. So they have to pay out of pocket. And then when you ask this patient to enroll on trial, so, because of the fact that they have to pay on out of pocket versus enrolling on trial, where the cost is most likely covered, then there's some ethical concerns there. Then the other question or concerns that raises when we talk about looking at trial from a patient perspective is that when you conduct a globalized trial, whereby there's a stipend given to patients, probably $5 or something like that, or $10, right? And that is written into the trial. Now you get to Africa, some parts of there's this thoughts that, okay, if we're going to give a patient $10 equivalent, that's a lot of money in African currency. Is this not going to skew them from, the thoughts as far as enrolling in clinical trials? So those are the questions as far as in the global space that is concerning when conducting clinical trials in places like Nigeria. All right, so the lessons learned from the West as far as conducting clinical trials in low-resource settings and minority population, because of that lessons learned, we decided to conduct a study in Lasot, that is Lagos State Teaching Hospital. And what we did was that we decided to say, okay, with all these challenges that's been talked about, what is the challenges peculiar to us? So we went to LASUT, whereby we assessed our patients and also the healthcare providers, all the healthcare providers in LASUT, to identify the barriers perceived by patients and providers in that institution towards clinical trials. And the reason why we actually involve the providers in this and not just put it only to patients is because we need to understand that the buy-in from local providers actually increases the chances of medical adherence. And also, if we are going to design interventions in that low resource settings, it's more likely to have a higher uptake. So what we found, what we did was we selected providers with the same specialties, we put them together, and then they were in that focus group together, and it lasted for about 20 to 60 minutes. And there was a good turn-up of providers, and we had 10 surveys being done, and then we had a total of 289 providers. And on the patient level, it was 4 focus group done. There were 5 participants in each group, and the patients were stratified by religion and level of education, and the total patients in that study was 20. So what we found out for LASUT, the identified barriers was they had a very poor attitude towards clinical trials, and most of them didn't even know much about clinical trials. They did not know that there was an ongoing clinical trial in the institution. They had low trust of the clinical trialist, and they were not collaborating well with the clinical trialist in the institution, and they were willing to get involved in clinical trial, or at least refer patients to us if they knew what it was. And then in the patient level, of course, the patient had low health literacy, which was already has been reported in literature. They didn't know anything about clinical trials. Family and friends were very, very influential in their decision to go on clinical trials. They lacked trust in the healthcare system, and they were concerned about the conduct of clinical trialists. And they wanted us to involve their local providers who had been their physicians before their cancer diagnosis. So what this means is that we have to really intervene. We have to intervene to educate the community and the stakeholders as far as ensuring community engagement in clinical trials if you're going to move forward. So these are the early phases of conducting clinical trials in places like Nigeria. And we should be able to work and chew gum together, whereby as we are conducting our trials, we should be thinking about how to be able to integrate this clinical trial into the healthcare system. So what I will leave you with is that what I have been able to see right now is that through cancer clinical trials, we can leapfrog in Africa and achieve global cancer equity. Through clinical trials, patients can get all these targeted therapies. The cancer care can actually be improved much better than what we have right now. And through clinical trials, we can also create a platform for drug negotiation by the country or by the nations through African Union to negotiate drug therapies for African patients. All right, so this comes to the end of my talk, where I'm putting the picture of Lagos, and hopefully we will be on our way to Lagos very soon after COVID. Thank you very much.
Thank you very much to both Dr. Fatiregun and Abiola. It's been very interesting, and you raised so many different things that we would probably need another hour to go through everything. Before I go through some of the questions in the chat, I wanted to just correct me if I'm wrong. There are several things that to me are very relevant, not only to Nigeria, but probably everywhere in the low middle income countries, which were mentioned when we talk about inequality. That Dr. Fatiregun actually, pointed out to different levels of inequality, from patients going to screening or to correct diagnosis, to possible treatment, insurance, And you, Abiola, you mentioned the clinical trials and people not being able to receive standard of care. And this also goes to a level, different levels of socioeconomic barriers, like money, lack of insurance, as always, also as education, as you mentioned, Abiola, and patients being aware of what is available to them and what they could do and why they would be they could benefit from these studies. So my question to both of you are, intervention is definitely necessary, but how can, and this problem has been there for a long time, what are the structures you think in the healthcare ward that can help the development of this infrastructure or improving the, for example, is WHO an essential component on making more drugs available? Are there like laws or structures in Nigeria or in the world that actually people should get together to face these inequality issues that everybody knows, but not many people actually can change. I'm interested in hearing from Dr. Fatiregun, especially from there. Like, you know, everybody agrees on what you say, but what do you see? What do you see there that could be possible opportunities right now?
Thank you for the question. I think one of the strategies would be advocacy. Now, why don't we have funding available for cancer treatment? Why do we have inequalities? First thing is that what's the political will, right, as a country to actually tackle this burden? In Nigeria, for example, we have the National Cancer Control Plan, right? At least we've been able to advocate to that point. Even in Lagos State, we now have a cancer bill that's based on advocacy, trying to keep pushing from every angle. So when we have the political will, definitely it's going to show up in the budget, and these treatments are going to get funded. While I was trying to do a search, with regards to cancer treatment in, a place like the US, I know there was a bill, the President Nixon declared a war against cancer, right? And it gave birth to several, the NIH, the granting system, and a lot of funds was pumped into cancer research. So we need to get to that point in Africa. That's one. Then the other thing is that because we are still at the infancy stage, still in that teething period, we need collaboration because we have to learn how to do it, right? So even if they give us so much money and we don't understand how to negotiate, how to navigate, and that's why I told you that whenever we have collaborations like this, I'm excited because I know that when you bring in the capacity from the developed countries and you're able to merge it with what we have now, there is growth. We are able to develop that area. Dr. Abiola talked about the clinical trial. That's my site, my unit exactly is part of that trial. And I tell you that now we have a biosafety cabinet. We have oncology pharmacy. We constitute chemotherapy using, in a clean room. Our nurses have been trained. We have study managers, and that's because there's this collaboration, because we need that capacity building from that part of the world. So I think we put those two things, those key things, along with other factors, of course, we definitely will reduce the burden in Africa.
Another question, I want to go fast so we can address more questions from Dr. Nyoku, actually, who's also from Nigeria, who's a faculty here. He's asking, based on what you said, what would be the most cost-effective method of reducing breast cancer mortality in Nigeria? Would you push for universal screening? Is there any collaboration between oncologists and primary providers in raising cancer screening?
Okay, so as clinical oncologists, one of the things we say is, why do you want to, yes, you want to screen, but I think optimal treatment too is key. right? So we can't actually focus on just one angle. Okay, you've screened the woman, and now she's supposed to pay $2,000 to get herself treated, right? She would even die of anxiety or even depression before the cancer takes her, right? So for me, from looking at from different angles, I would say that we have to, first of all, we must be conscious that it's not just about screening, it's also about access to care, right, in Africa. And that's why we keep pushing from the political end. We're able to collaborate. I've had several sessions with private practitioners. We need to fund the National Cancer Control Program, because that cancer control program actually speaks to everything. It speaks to screening, it speaks to treatment, it talks about PPPs. I talked about radiotherapy centers springing up. There's a model of PPP. It talks about insurance inclusion. So we really need to fund the cancer space, the National Cancer Control Program, across board. It's not just about screening. I think there's much more that we need to focus on.
I think there's a question that maybe Abiola could answer from Bani Medigan, who is asking, do you encounter hesitancy in joining clinical trials due to cultural beliefs or lack of trust in the system? For example, not wanting to be guinea pigs, as we have seen with COVID vaccine hesitancy.
Yeah, so the thing about clinical trials, or rather the science, is that there is a lot of misinformation and disinformation about it. For example, the COVID vaccine uptake in places like Nigeria is not as high as you would expect it to be, because again, there is this war against science, right? So when we talk about clinical trials right now, as far as the cultural belief, it's more of religion, whereby when a person is on trial or whatever, and we've seen that happen right now in our ongoing trial, whereby probably the pastor, somebody tells them something and then they either not join the trial, or they don't even want to take treatment, or they move on and get themselves out of the trial. So yes, we encounter our issues as far as religion, cultural beliefs, and then as far as the trust in the system. Unfortunately, cancer does not have a good rap sheet in Nigeria. People would prefer to have HIV/AIDS than to have cancer. Why? Because our colleagues in the HIV world, they've been able to show progress whereby a patient gets diagnosed and they get treatment and they're alive. But in cancer, we say a patient should get diagnosed, and most likely they're going to either get very, very sick or they die from the cancer diagnosis. So until we show a very good, which speaks to what Dr. Fatiregun said, we have to address the treatment and optimize it in the country. I think that that is going to tie with how our patients respond to treatment or clinical trials.
A couple of questions more on specific on breast cancer. One is from Hoda Sayeg, who's asking, I'm aware that prevalence of inflammatory breast cancer is much higher in North Africa than compared to high-income country. This is well known. Any research done on it? And another question, maybe can be answered the same together, would be, do Nigerian women with younger age at first pregnancy have a higher risk of breast cancer than Nigerian women who were older at first pregnancy? And are women with more children at higher risk than women with fewer or no pregnancies? So inflammatory breast cancer and higher risk in early pregnant or no, and more children?
So, with regards to inflammatory breast cancer, I know we've tried to get a couple of grants to help us study that topic in Nigeria. But up until now, we haven't been successful. So we only have international studies, relating to that topic, but not in Nigeria. And also separating women who had early pregnancy and late pregnancy. We just know that most of our patients, like I mentioned, they definitely have earlier, most of them, of course, poor health literacy, most of them have early, they get pregnant quite early, right? But studies have not actually separated the two cohorts, like, okay, this woman had her she's nulliparous, had first pregnancy at this age. I haven't seen studies separating those two cohorts together. We just know that generally Nigerian patients would have their first children at an earlier age. And it doesn't really relate to breast cancer incidence. We just know that they come in premenopausally when they have a diagnosis. Yeah.
Another question from Martin Boslan is, are lumpectomies and sentinel lymph nodes procedures done in Nigeria?
Yeah, so lumpectomies are done, right? And that's one of the things we're trying to change. We want the women to get cord needle biopsies. But most of the time, like I mentioned, there are only 83 clinical oncologists in the country, right? And we're still advocating and we're trying to push for it. But most of the time when women go to the GPs, like the community hospitals, right? Or those are private hospitals that are closer to them. And they say, oh, there's a lump in my breast. They take it out. And then a woman shows up to your clinic with mastectomy. I'm like, why, right? But of course, when you look at the private settings where you have specialists, you have surgical oncologists, they would do a cord needle biopsy. They would do a sentinel node, but what is the coverage like? It's still low. And that's why we have to keep educating. We have to, even the clinicians, the team itself, in trying to ensure we give them standard of care. And that's why research is so important, right? Yeah.
Does Nigeria have a training for medical oncologists? Like, is there like a formal training, a fellowship in medical oncology? No.
No, not yet. What we have is clinical oncology. And because you can see that oncology still is in its infancy stages, we modeled our training, with the UK training. Most of our professors got their training in Manchester, Birmingham. And so when they were setting up the training, they actually made it a clinical and radiation oncology training. So you have two groups of clinical and radiation oncologists, those who work in centers that don't have machines, whereby they offer more of clinical oncology service, and those that work in centers where they have radiotherapy machines. But of course, definitely we're trying to expand the field, and then would be looking into developing the medical oncology space. It's important.
So Abiola, in order to develop clinical trials in a country with 200 million people live, and Lagos has a city, if I correct, has 20 million inhabitants. How many staff would you need? Like, you can have an amazing doctor there, and then the infrastructure is not only the doctors, it's nurses, research staff. This seems like a capacity that will require a lot of efforts and also a desire to have it in that space. How feasible is it right now to envision a robust clinical trial infrastructure?
All right. So Rome wasn't built in a day. And in the United States, clinical trial infrastructure has taken over a century to build. So we are in our infancy, like Dr. Fatiregun said. So right now we have, each institution has a trial nurse designated for that study, a study nurse, and we also have a data manager designated for the study. And then we have the PIs, we have the sub-PIs, and then we have pathologists and what have you. So, and we are building capacity as we are beginning to expand our sites for clinical trials. Of course, we are expanding people and we are getting more people on the trial. So as at now, we have one data manager and a study nurse for about 3 studies ongoing. So as their work continue to expand, of course, we are going to start expanding and employing more. And the good thing is that even though the studies are being funded by all this foundation and the salaries of these people are being paid like that, the hope is that at some point the policymakers will be able to pick up the tab and continue to pay the salaries of those people.
Okay, well, there are more questions on the chat. I think that, however, our time is over. It's already 1:15 here in Chicago and late in Nigeria. I really want to thank both of you. It's been outstanding. A lot of congratulations messages on the chat. I really enjoy and I really appreciate Dr. Ibraheem organizing this seminar and having Dr. Fatiregun. I hope we will have you again soon in our not only seminars but also in our work. And we look forward to working with you through Abiola, but also through anybody here who can actually help. Thank you very, very much. And thank you for all those who have attended and are still on the call. Thank you very much.
Thank you for having us.
Thank you for having us. Yeah.